Hi, my name is Jayana Devathasan. I am a medical registrar at North Shore Hospital. This is an audit that we did last year when I was a renal house officer at Murumo, probably in May. And so I thought I'd use this opportunity to present it here. So it stemmed from the fact that when I was a house officer in renal, 3 months only, we had a lot of patients with Staphylococcus aureus bacteremia. And it's a beautiful beautiful bug, it's golden, but it can have devastating complications. And so that's kind of why we wanted to look into it and see what exactly was this burden and what could we do to improve our practice. So just background on hemodialysis. Hemodialysis is one of the mainstays of treatment for end-stage renal failure. It requires vascular access, and you are basically needing vascular access to filter a large volume of blood. And there are a couple of ways to access the veins and the arteries. The preferred way is the fistula, so you want to create a surgical anastomosis between your vein, your artery, and use that. The thing with a fistula, you need to be able to undergo surgery to have it. You need to be able to have a degree of planning beforehand, because once you have a fistula created, it takes several months to mature and be able to be used. And so the other option is a central venous catheter, and often in someone who's having chronic dialysis, you use a tunnel line. And the advantage of this is that you can put it in on the ward if you need it. You can use it straight away, but then obviously it does carry infection risk. So the dialysis population are not the healthiest bunch, and uremia itself carries a degree of immunosuppression, as well as you've got your other comorbidities, you've got patients who've got diabetes, and some of them are on medications that are immunosuppressants for underlying kidney disease. And it's not surprising that infection is the second leading cause of death after cardiovascular disease, and having a central line is one of the biggest risk factors. So the incidence of Staph aureus bacteremia is about estimated at 3 to 4% in the dialysis population. It's about 50 times greater than the general population, and again, it can have devastating complications, as I will talk about. So this was a very quick audit that we did last year, and we just wanted to see, look, how in the 3 months that I was there, we had at least 5 patients a week, and you're trying to figure out if this is actually representative of, this 3 years. Is this normal? Is this high? And so essentially, we wanted to figure out what exactly were the numbers, and then using this to identify some demographic features, and then also look at management. Very briefly, looking at methodology, because it was an audit, so it's quite straightforward. We had a lot of databases available to us. So we had the lab records, we had Concerto, we had Clinical Vision, which was a renal database that we were able to use. And what we did, the lab was able to identify all of the patients within this 3-year group that had Staphylococcus aureus bacteremia. Then we figured out which one of these patients were hemodialysis patients, and then we used that as our data set to figure out risk factors and so on. So from the 3-year period, there was 435 episodes of Staph aureus bacteremia. And of these, a quarter of them involved hemodialysis patients. And of those 105, a quarter of them had recurrent episodes. And so the data set we were using basically covered 80 patients. Basically, demographics, you can read really the slide for yourself, but essentially the demographics of the patients involved were slightly older, slightly overweight males with a high predominance of Māori and Pacifica males. And actually, anecdotally, that does represent the demographics of our dialysis population. In terms of clinical characteristics, the majority of patients had diabetes as their etiology of end-stage renal failure, and this was a significant risk factor for infection, as well as previous Staphylococcus aureus bacteremia. At the time of infection, 60% of patients had a fistula for access, whereas the remainder, so 40%, had central venous access lines. And to put that in context, about 15% of patients getting hemodialysis have central lines at the moment. And so there is a disparity there, so having a central line is a risk factor. And of those who have central venous lines, there are a couple of reasons why they have those and not fistulas. Some of them don't want a fistula, some of them can't handle the surgery for a fistula, and the majority have suboptimal starts. So they present acutely, they present uremic, they present with acute AKI, And so you've just got to do something. You can't wait 2 months for the fistula to be created and mature. As expected, the majority of infection was related to access, so 60%, and 20% were MRSA infections. There was a high rate of complications, so we had a 40% complication rate, and these really varied, some like endophthalmitis, and then you've got your bone and soft tissue and joint infections. And some of them required surgical intervention and others required prolonged therapy. And again, there was a high 30-day mortality of 8%. Of the there were 7 patients who died. 5 of them were related to Staph aureus sepsis and its complications thereof. 1 died from a STEMI, and 1 had aspiration pneumonia. Just very briefly talking about management. So everyone who had Staphylococcus aureus bacteremia, whether they presented acutely or whether they came in via their dialysis units, were managed as inpatient. They all had involvement from the infectious disease department. And of the ones who had infection related to lines, the lines were removed. Almost all of them had an echo, and a good majority of them had blood cultures cleared before they were discharged. In terms of duration of treatment, again, it varied based on complication rate. So the ones who had 2 weeks were those who had uncomplicated line infections where we were able to achieve source control and remove the line. And obviously, as complication rate increased, you'd have a longer amount of treatment. 2 patients there were supposed to have lifelong treatment. One had septic arthritis and a vegetation on the heart valve. Wasn't an operative candidate, and so the plan was just for long-term treatment because you had multi-organs involved. And the other one had a mycotic aneurysm of one of their coronaries. And so the plan was to continue antibiotics, and actually the patient, a couple of weeks later, had a STEMI and died. In terms of management, antibiotic choice, again, it really depended on the sensitivity of the bug. Really, the mainstays, Fluclox for MSSA, Cefazolin for those which were MSSA and uncomplicated, and vancomycin for the MRSA infections. And I guess one of the good things about having infections in hemodialysis patients is that you get quite good at managing them, and you can use dialysis to your advantage. So those patients who received vancomycin or cefazolin, they were able to get those antibiotics at dialysis instead of needing an extra PICC line, which invariably resulted in longer stays and more complications. Just very briefly, running through a few of these slides, we sort of looked at complicated infection and sort of looked at these risk factors to see if there was any sort of discernible risk factor that would lead to a complicated infection as to not having a complicated infection. Essentially, there was no statistical significance. 30-day mortality, again, no statistical significance there when you compare age, diabetes, access, MRSA. And for recurrence, there was probably a higher predominance of diabetic patients in those who had a recurrence, and actually a lower MRSA burden in those who had recurrence. Summary of findings, essentially this audit told us things that we probably already knew. And I guess that's the thing with an audit, you sort of end up with a lot more questions than what you started with. And we were able to quantify just over this 3-year period that there was a significant burden. And compared to sort of global, I guess, rates, we did have a higher rate of complications, high mortality. And it became apparent that rather than saying, look, this risk factor, treat with this or this, it really does require an individualized approach based on risk factors, comorbidities, patient factors, those kinds of things. And I guess in terms of discussion, there's a lot of questions still, and I think it'll be quite interesting to compare our rates compared to Auckland, compared to Waitemata, compared to the rest of New Zealand, and sort of see if there's any trends there, and essentially, if possible, to avoid central lines and references.